in fact, if you go on a really low carb diet, you actually induce a little bit of glucose intolerance. So then if you have any, glucose, it'll spike even higher. Like for pregnant females who always have to get a glucose tolerance test to check for gestational diabetes, we tell them not to go low carb going into it. So because they sometimes think, oh, I'm going to, just so I don't end up with gestational diabetes, they go on a little bit low carb diet, but actually it can then give us almost a false positive because they induce a little bit of transient insulin resistance or glucose intolerance, actually.
What's up, my friend? I'm health expert Ted Rice, and today I'm coming to you from Bangkok, Thailand. I just finished up a Muay Thai class, so I'm riding high on endorphins, adrenaline, a little bit of cortisol, and some boi loi, which is a ginger broth with these dumplings that are filled with black sesame and a little bit of sugar, I guess, because it's nice and sweet. Of course, that was my dessert. Anyway, today I am super excited to share this episode with you because it's with endocrinologist and diabetes expert Karl Nadolsky. But first of all, it's Christmas time. And before we get to the episode, I want to tell you, enjoy Christmas. Enjoy spending time with your family. Enjoy the connections, even if Uncle Bob gets a little bit drunk or Aunt Nancy starts to give you a hard time about, how you're trying to eat better or whatever it is. You know what? Have some empathy. Our families aren't perfect and neither are we. So do a little meditation, get a little workout in, and go in there ready to connect with people and just be yourself and let them be their self and be the person, be the leader, be the inspiration, be the person. I'll tell you a really quick story. I had to be the one to change so that my dad would change. So that's my little bit of advice. If you want the people to change around you, you got to be the leader. And that's why I'm so excited to tell you that I'm releasing a new series on December 30th. It's going to be 3 episodes long, and it's going to be about everything you need to make 2020 your year. And no, it's not just going to be about nutrition and exercise, although that will be part of it, but really everything. So I'm super excited, and we're going to release it on December 30th, Monday, December 30th. So stay tuned. So let's jump into today's episode where we're going to talk about diabetes. What really causes it? Is it hormonal? Is it just high insulin? Can you get diabetes on a low carb, high fat diet? We're going to get into all that and more. And more importantly, what can you do to reverse diabetes? I'll tell you what, I had pre-diabetic blood sugar levels for a little while, and I was starting to freak out about it because I was on a low carb diet. So if you're interested in avoiding diabetes, or perhaps maybe you're already pre-diabetic or having some issues with blood sugar, you're going to learn so much with endocrinologist and diabetes expert, Dr. Karl Nadolsky. So let's jump into the episode. Dr. Karl Nadolsky, thanks so much for coming back on the show, man. Excited to speak with you.
All right. Thanks for having me.
Yeah. And what I really wanted to cover today is some of the talk out there about diabetes, how it happens, what's relevant to what causes diabetes, because there's a lot of talk out there. In fact, I sent you an article from a very well-known and unfortunately well-respected health and fitness influencer talking about glycemic variability and how we need to, pay attention to this, even if we don't have if we're not pre-diabetic or diabetic. So let's start like this and then we'll jump in, because it's been over a year since I've had you on the show. Can you just briefly run us through who you are and what it is that you do?
Sure thing. So, Karl Nadolsky, I am a board-certified endocrinologist and a diplomat of the American Board of Obesity Medicine. Also currently happen to be serving as chair of the American Association of Clinical Endocrinologists Obesity and Nutrition Disease State Network. And I work in Western Michigan now. I was in the military for 9 years, did my internal medicine residency and endocrine fellowship in the military. Endocrine fellowship was at Walter Reed National Military Medical Center in Bethesda, and then got out 2 years ago, moved home to Western Michigan, and am now practicing endocrinology with a big group here.
Very cool. And what I think is important for people listening is that there's a lot of talk out there about hormones and fat loss and hormones and diabetes, in particular insulin. And you are an expert in hormones. You went to school to be a medical doctor, then ended up specializing in endocrinology, especially with a focus on helping people with obesity and diabetes. Is that correct?
That is correct.
So let's maybe even just do it like this. A lot of people are under the impression that it's carbs that cause fat gain, and it's carbs that cause diabetes. Can you just talk a little bit about the nuances there and what we should know as health and fitness consumers who are interested in staying healthy?
Yeah, so certainly that is, sort of a cut and dry, I guess I would call it a fallacy, although it's not necessarily wrong. It's just not necessarily right, if that makes any sense. So, if we think of obesity as, a disease of excess adiposity that causes harm, that's the result of a complex genetic, physiologic, environmental factors that cause essentially a dysfunctional homeostasis or imbalance and a positive energy balance, which really, bottom line, despite all that complexity, is a caloric consumption more than energy expenditure that leads to the accumulation of adipose tissue. Now, where it gets stored plays a role with what we're going to talk about, but there are all sorts of genetic and hormonal factors within each person that can influence that whole axis. But
and Dr. Karl, before we hop into that, I just want to go over the point that you talked about, the positive energy balance, or otherwise known as overnutrition, or otherwise known as eating too many damn calories compared to, what you're burning. Is that a controversial concept in evidence-based medicine? So with the best research, is this a controversial concept that positive energy balance or eating too many calories relative to the calories that we burn? Is that controversial or unproven?
No. Only when you start getting into the people who, for some reason, have an agenda for it to be something else. Like you said, the people who say it's only carbs, or for some reason that it's actually insulin that's the underlying cause as opposed to a consequence. Really, and like I said, it is a complex equation on both sides of it to some degree. There are genetic factors that determine set points for appetite and metabolism, and of course, physical activity influences metabolic flexibility. There are environmental factors that put us at risk, prenatal factors, epigenetics. And then, of course, we live in what we call an obesogenic environment where we have tons of inexpensive, palatable, energy-dense foods that overwhelm us. And that's to some degree where that whoever says carbs cause obesity, it's not necessarily wrong, because if we are surrounded by just hyper-palatable, energy-dense carb sources, yeah, we're going to overeat them. And it's hard to not do that. But the same goes for the fat. And even to some degree protein, even though protein is probably the most energy efficient macronutrient.
And let me ask you this, with all the research that's out there that has looked into this, most recently Kevin Hall's articles comparing ketogenic diets versus low-fat diets, and looking into what's known as the insulin carbohydrate model of obesity, and just saying, hey, there's no evidence for this. There's just none.
Right.
Why
there really isn't.
Why is it so controversial? Other than the marketing, because not everybody is just doing it for marketing. Let's just play, devil's advocate, I guess, and say not everyone's doing it for marketing. Why are scientists who have easy access to this information, who have the foundational science and statistical analysis, why don't they just look at the papers and say, oh, well, this is so obvious what this is?
Well, so we talk about this a lot, and I don't know that I can give you the exact answer without really getting in their minds. So I think it might have to do with the fact that their research has focused on this their whole lives. If what they've kind of shown to some degree, so there is some evidence to what they're trying to say, at least some theoretical and some experimental evidence, I guess. If what they've been doing their whole lives is kind of wrong and not even within the realm of possibility, then maybe that means they feel like they've wasted everything. I don't know. That's one thought that we've had as to why they keep, really trying to push it like it's an agenda as opposed to, just discussing it.
Yeah, that's an interesting point to make. And it's something that drives. Now, there's just a group of people who have been attacking me on Twitter lately about the fruit, low carb diets, and especially the carnivore people. And by the way, I appreciate if you're listening and you're a keto person and a low carb person and you just say, hey, you know what? It works for me. It's the way I get into that negative energy balance to lose fat and then, maintain my weight. Totally respect you. But it's just like this tribe of people, including the leaders, if you will, who are scientists or, journalists in the case of Gary Taubes, who are kind of leading this. And so let's move on. So what you kind of said was having excess body fat is what drives the development of
obesity,
and then eventually, or maybe not eventually, but it could turn into diabetes. But how we get obese is just positive energy balance. So it could be from fats, could be from carbs, and you said even from protein.
Yeah, potentially. Just less likely, I guess.
Let's just open that up just a quick second before we move on, because I've gotten into it with actually RDs, and they're like, oh, look at this study. You can't get fat on protein. Can you give us some, obviously, I've talked about protein, the higher thermic effect of feeding.
Yeah.
And all that, but
so certainly it is. I mean, I would say that that's better, and I recommend more protein, generally speaking. The vegetarian people, this gets into the extremes for whatever reason of dietary therapy. You got some people that think, well, we have to all be vegetarian, and then some people that think we have to all be carnivore. But the truth is usually lies somewhere in the middle. But the deal with protein, I mean, it is a more efficient. Has the thermogenic effect of the food. It's a little bit more efficient. It's satiating. It's muscle preserving, building. So it is important whether it comes from quality animal sources with full amino acids or even from a variety of plant sources. But you certainly can over consume it and overwhelm the body's homeostasis and get adipose tissue from it, but less likely. So yeah, we do. I mean, when I give prescriptions, especially for people with obesity and diabetes, I'm going to try to crank up their vegetables, which are low carb, low fat, high fiber. I'm going to try to get them more protein, generally speaking, especially lean protein, so we don't overdo the fat. And I do try to cut down the carbs from processed, refined sources because of that, high energy, hyper palatable risk of it just overwhelming the body's set point. And everyone's different with genetics and ability to, we're going to get into, peripheral healthy adipose tissue versus ectopic or visceral adipose tissue, where it gets stored and overwhelming that system. And everyone's different. But, I definitely push probably a lower carb, relatively low fat, but getting fat from nuts and seeds and fish and olives, a little bit more Mediterranean spin, and a lot of vegetables, high beans and legumes, and some fruit. I certainly don't tell people to avoid fruit, although it seems like the past few days with patients with diabetes, we've been splitting some hairs between berries, the more moderate fruits like apples, pears, and then the high sugar fruits like bananas and pineapples. So, if they're to a point where we can split those hairs, we can do that. But usually there's lower hanging fruit, if you will, no pun intended, or maybe intended.
Yeah. And let's talk about this a little. People are so confused. And one of the reasons I see, at least, is because they don't understand the information or who the information is good for. For example, if you're telling me, hey, don't eat fruit spikes your blood sugar, and I'm at 11% body fat right now, and I'm training hard with 2 Thai kickboxing sessions per week that last in between 90 minutes and 2 hours.
That doesn't make any sense.
Doesn't make sense.
So that doesn't make any sense, no. And because that's not going to really happen, and it doesn't matter. And that's going to get into when we talk about the glycemic variability issue, especially in healthy people.
Let's talk about that, because there's, well, you know what, I'm just going to say it. Ben Greenfield
I think we got to go back
that.
to we got to do at least a little physiology of the development of type 2 diabetes, though, to understand that. So, we talked about the adipose tissue, the excess adipose tissue, and, we like to call it adiposity-based chronic disease, and that leads to maybe what we could coin dysglycemia-based chronic disease. So when we start to have that overwhelming adipose growth, our healthy fat cells, like our peripheral, subcutaneous fat, like on our legs, for example, that usually take up the glucose and store it as fat, they become inflamed and and start to actually have increased lipolysis and then the fat starts to get stored in our liver, our visceral, around our organs, our visceral adipose tissue. It gets in our muscle cells, so our muscles become insulin resistant, and then it also starts to get stored a little bit in the pancreas, which ultimately leads to some pancreatic failure. So the pathophysiology of diabetes is very complicated. So we have dysfunctional healthy adipose tissue, dysfunctional visceral and ectopic adipose tissue, the fat in the muscles that's making the muscles not work well, the fat in the liver that's making the liver produce increased glucose. Then we have the areas in the brain that are supposed to be controlling our energy homeostasis, and that set point gets changed. We have increased appetite, changes in sympathetic tone. That's maybe more complicated than we need to get into, but it causes problems. As you might know, and a lot of your listeners might know, the gut microbiome plays a big role in all of this, in both metabolism and potentially in diabetes. There's inflammation, dysregulation of the immune system, and then our intestines that play a role with what we call incretins, those hormones that improve pancreas function, improve satiety, slow down the stomach, and keep glucagon from taking the sugar out of the liver. Though that becomes dysfunctional, and then even the kidneys. There's an upregulation of the transporters that make us keep more glucose in than urinating it out, even though at some point with hyperglycemia, if we get to that point, we urinate out too much sugar. And then ultimately, the pancreas is trying to keep up with it, but then it, especially because of the fat that's in it probably, starts to have decreased beta cell function, mass, and ultimately not enough insulin to keep up. And that's when hyperglycemia ensues, to a point at which it causes complications in the long run. And it's at those points that we have diagnostic thresholds for diabetes. Before that, pre-diabetes, and before that, we can, talk about some of the more nuanced insulin resistance, adiposity-based dysglycemia, I guess is what we would call it. So that's a lot of stuff leading into glycemic variability, but you got to have at least some aspect of why we're
Is there going to be a test at the end of this?
Insulin resistant. Yeah, definitely.
So, thank you so much for providing that context. And even though we're not all listening to you going to memorize what you just said, it at least paints the picture of how complex this is and why we shouldn't maybe listen to someone who makes a Twitter thread or an Instagram post trying to explain diabetes. Let's make sure we talk to guys like you so that we can understand the nuances. And that's why I love doing this podcast. I would love for you to answer this question, because this is something that I was asked and I gave my answer to it, but I would love to hear you answer it. Can you get diabetes from a low-carb, high-fat diet?
Yes. And, again, it comes down to that, that adiposity-based chronic disease. If we overwhelm the system and we end up, causing dysfunctional healthy adipose tissue and ectopic adipose accumulation, that's going to cause it. Now, the reason a low-carb diet might help people with type 2 diabetes is because if they're not having, and we're going to talk about this, if they're not having those prandial or post-meal rises in glucose, then they're keeping their at least glycemic control fairly well done. But then that doesn't necessarily fix the underlying physiology or pathophysiology and other problems that go along with it. In fact, if you go on a really low-carb diet, you actually induce a little bit of glucose intolerance. So then if you have any, glucose, it'll spike even higher. Like for pregnant females who always have to get a glucose tolerance test to check for gestational diabetes, we tell them not to go low carb going into it. So because they sometimes think, oh, I'm going to, just so I don't end up with gestational diabetes, they go on a little bit low carb diet, but actually it can then give us almost a false positive because they induce a little bit of transient insulin resistance or glucose intolerance, actually.
Let me just restate that for the people listening. So a low carb, high fat diet or a high carb, low fat diet, any diet that puts you in a positive energy balance, as you said. In other words, you're taking in more energy than you burn, is going to make you put on body fat. And if that happens long enough, there's this strong potential, depending on where that fat gets stored. If it starts getting stored in your muscles, you develop insulin sensitivity in your kidney and pancreas and all the things you mentioned. So you can get diabetes just overeating. And it doesn't matter if you're on a low carb diet or a high carb diet. But what you said was that if you do have diabetes or pre-diabetes, let's say, you can lower your blood sugar levels or your hemoglobin A1C or whatever your biomarker you guys are using, but you still have diabetes. You're just controlling it with a low carb diet, and it's not fixing the problem, because the problem only gets fixed if you lose fat, which comes from
pretty
negative
much.
energy balance.
Yeah, for the most part. Like I said, the complexity of the pathophysiology is so much more. Then that's where we get some of our medications. But yes, that is like the bottom line, especially for diet. However, with a little bit of caveat there, I still think there's good evidence for some of the quality dietary measures. For example, the best data I think we have is for Mediterranean pattern diets. Despite the caloric load, people who, every time they study nuts, almost like in randomized controlled trials, like the Predimed trial with nuts and olive oil, but even just any type of nut, pistachios, walnuts, pecans, every time they study those, there seems to be improved cardiometabolic, at least markers. And that can be diabetes, that can be lipids, blood pressure. So, pushing a higher vegetable, higher fiber, beans and legumes, nuts and seeds, fish, quality protein diet seems to have benefits almost regardless of weight change. And so if, for example, eating those types of fats instead of, buttery animal
putting butter in your coffee,
fat meat, right?
And eating ribeye steak,
which I'm still in the middle of that trial, but yes, exactly. So there's something definitely to quality of diet in addition to pure straight energy balance as far as the cardiometabolic outcomes.
No, thanks so much for saying that, because it's super important. And in fact, I looked at a couple of studies, and when I say looked, I just read the abstract. I didn't go deep into it. It's really not my thing. I talked to guys like you and your brother and other experts to kind of break down the research. But what it was saying is that overeating saturated fat in particular can cause an increase in fatty liver. And there was another study that my coach shared with me, who's getting his PhD in nutrition, on how overfeeding mice saturated fat is the fastest way to give them diabetes. Can you just maybe talk about the nuances a little bit more? Like, why do you think that's happening, this qualitative difference in diet versus just the calories?
Oh, that's pretty complex and would probably take a whole nother hour.
We got about 10 minutes left before you got to go. So,
but as it has to do with lipid metabolism, probably liver, the effects on the liver of lipid manufacturing and metabolism, and that insulin resistance we talked about. There are just different effects of those different types of dietary lipids, and certainly fiber seems to help too. That's where we get into the higher fiber foods and things like that. But I think the bottom line is that the studies like Predimed and these other studies importantly just show the biomarker benefits and make it worth improving the quality diet, as opposed to otherwise.
Just eating ice cream, drinking beer, and going to
Right.
McDonald's,
So-
but keeping your calories in under.
Right, exactly. So
Yeah.
I'm not one of the, I don't push the, well, if it fits your macros, bro, sort of thing. The quality matters. It just does.
Sure.
But quantity, is probably number one overall.
Yeah. I would say this. I've gotten to be, I was a really, a food purist in trying to get everybody to buy organic and do all these things. But now what I do as a coach is I meet people wherever I can to get them results. And as they start getting results and they start changing, then I start looking for the ways to improve.
Yeah.
And
I agree.
Yeah. And that's something I would say to anyone listening who's looking to improve. If you hate vegetables, just find a way to get into that negative calorie balance so that you start losing some fat and feeling better. And then, when you're looking to step your game up, try shifting over from some of the more processed foods to some of the things that Karl talked about. Karl, let's talk a little bit about glycemic variability, what it is and the relevance to someone like, because I'll just say Ben Greenfield, who, I'll just put it like this. I don't learn things from him about physiology, but I definitely pay attention to the way he markets and have learned a lot from him about that. But one thing he talked about was glycemic variability and longevity. And he's not the only one. There are a lot of people, I guess Dave Asprey's another one, talking about, managing who they're not pre-diabetic, they're not diabetic, but they're talking about controlling your blood sugar. Can you just talk about the glycemic variability and how important it is to a healthy person?
So, glycemic variability is somewhat of a new concept because we have such better technology in diabetes, maybe more importantly in type 1 diabetes, rather than what we're talking about is really type 2 adiposity-based diabetes. But glycemic variability is essentially just the standard deviation, or what we call a coefficient variation of your average glucose. So, for example, especially with type 1, but we also put this for type 2 diabetes, a good goal average glucose is to be under, say, 155, which kind of correlates to a hemoglobin A1C of about 7%. So just for everyone, the A1C is essentially the sugar on your red blood cells over 3 months. That gives us a decent correlation to average sugar, but it is flawed also. All these things are somewhat flawed, but we think continuous glucose monitoring is a little bit better. And so the standard deviation of the variability is, well, if your average sugar is 150, we would like that standard deviation to be less than, say, 50, or a coefficient variation less than a third. Does that make sense? So, if your average
Not exactly,
is 150,
Karl.
well, so we'd like that standard. We want the coefficient variation or the standard deviation to be less than a third of what the average is. But here's the deal: is that we think, based upon a lot of biological and preclinical studies, that matters significantly, but we don't actually have evidence that reducing the glycemic variability has proven to be independently effective for like diabetes outcomes in outpatients, essentially. While we have these goals based upon all the evidence, we don't know exactly, where they go. And there are some people in the diabetes world, especially type 1 diabetes, who are very convinced that this is the most important thing. And so we really think we do think it's a big deal, and we try to get it right. But it also correlates to people with type 1 diabetes or type 2 who are on insulin with preventing low glucoses. We know having hypoglycemia is very bad. We know that having postprandial or post-meal hyperglycemia spikes is pretty bad. And so then we have these studies essentially showing that more glycemic variability in people with diabetes, especially type 1 diabetes, is more inflammatory. There's maybe more endothelial dysfunction with it and all these things. But what happens, if we control someone with type 2 diabetes better with diet, exercise, and the medications that we have, they're going to have pretty minimal glycemic variability. And then what you're getting at even more interestingly is these guys that are biohacking and saying, oh my God, we all have to have like this perfect glycemic variability. Well, it turns out, and I can give you the most recent study looking at healthy people with on continuous glucose monitors. We don't have much glycemic variability. And so the healthier you are, the less insulin resistance you have, you're not going to have much glycemic variability. So their whole premise, while in type 1 diabetes, we think that is probably true. In type 2 diabetes, certainly probably is true. If nothing else, it probably is a marker of how well they're doing. Same with the pre-diabetes, but they're not going to have much glycemic variability either. So if we put a continuous glucose monitor on you, you'd have hardly any glycemic variability. It would be minimal compared to someone with like type 1 or type 2. And so the most recent article looking at this was in the Journal of Clinical Endocrinology and Metabolism. I think, in fact, it was published online in April. Just for anybody who wants to look at this, it's called Continuous Glucose Monitoring Profiles in Healthy Non-Diabetic Participants, multi-center prospective study. And so they had over 150 people that were healthy, and these are not athletes, mind you. So if we're kind of getting into the people who are really, really taking care of themselves, have low body fat, they're exercising all the time, that's going to be even less relevant. So in these people, the average glucose was 98 to 99. That's normal even for a fasting glucose, let alone an average, including meals. You know what I mean? And then if you were over 60, it was still only 104. And then the median time between 70 and 140, which is like optimal for anybody, was 96%. So compare that to our patients with type 1 diabetes or type 2, we want them to be over 70% there.
Right.
And then, and for example, so if what I was saying, the coefficient variation, our goal for now is essentially 30%. We'd like it less than that. So that's like a third of what the average glucose is. So the mean within individual coefficient of variation in this group of non-diabetic patients was 17%. And only 2% of the time were they over 140. And in fact, they were even under 70 1% of the time, because it's not abnormal to have kind of mild hypoglycemia in normal, healthy people. So for athletes like us, or for the people that are probably listening to Ben Greenfield, I don't know, they want to wear CGMs and think that they're going to improve their longevity by somehow improving that glycemic variability that's already minimal. Oh boy, that's really stretching it. We don't even have the evidence in people with type 1 diabetes yet to absolutely say with definition that it improves longevity.
What if he's ahead of the science, Karl?
Well, the thing is, he's using our science to hypothesize, and that's great. That's totally fine. We hypothesize that too. We think it's very important. We do. I mean, every type 1, I talk about it, and even the type 2s. I have my goals. We try to minimize it. We can't say for sure that it matters as much as we think. We think it does. We're going to have to wait for trials to say it does. I would just as soon keep my glycemic variability down too. But the thing is, it is like healthy individuals have hardly any glycemic variability. There should not be. And if you have it, that means you're not that healthy. and then you should continue to improve your dietary habits, your eating. But an athlete who has healthy carbs, because they need carbs for working out and all that stuff. I mean, we know, bodybuilders and athletes have pretty high carb diets, lower fat usually, but they don't have huge glycemic variability. Maybe we need to study it. But it's going to be impossible to show any statistical significance in longevity from that. It's all very, very hypothetical, and I would say really stretching it in normal people. I don't know how that could be there. I mean, we have to find it in people with diabetes first.
Well, we're kind of running out of time, but it would be interesting to talk about all the things that people don't talk about, like social isolation, loneliness, the inflammation, and immune system suppression that's been shown to negatively affect someone's life. And we're all in deep down the rabbit hole about these things that probably, if they even matter at all, they only matter just a tiny sliver.
Right. And they might be more of markers of those bigger things that you're talking about. So big picture, it's one of those forest and the trees, getting lost and, all that stuff. It's like, yeah, I certainly would not tell any normal people to start wearing a continuous glucose monitor and checking their glycemic variability. We have much lower hanging fruit to deal with, I promise.
Well, listen, Karl, really appreciate your time today. You got to run to your first patient, but
yep, first patient's ready.
So I really appreciate it because this is helping clear up so many people. Now there's people who are going to follow those other people and they're going to wear those things and not care, but
yeah, and it's not going to hurt them.
Yeah, it's just wasting your time.
And it's fun. And trust me, I've worn it and given myself anxiety because we have to learn about them. So when we were out, I'll just tell a quick story. The last time when we were endocrine fellows several years ago, we went to this, what we call endocrine university. It's kind of the last thing we do. And we all got to wear continuous glucose monitors and we're all sitting there drinking coffee, which, raises your glucose a little bit at the time, even though coffee is good for you overall. And we're all sitting there with glucoses like in the high 90s, once in a while getting over 100, freaking out because, we're people too, and we're endocrinologists that probably overanalyze ourselves. So I understand it, but it really probably shouldn't matter that much for us.
Got it.
But it's fun, no harm, but don't freak out about it.
It's, if you want to experiment, go for it. Just understand what it means and the evidence supporting it. And but if you want to, go for it. Well, Karl, thanks so much for coming on today. Do you want?
Sure thing.
Where would you like people to connect with you if they have any questions about this or?
Probably, and I'll share it on my Facebook page, my Dr. Karl Nadolsky Facebook page, and on the Instagram at Dr. Karl Nadolsky, and I suppose Twitter. And maybe we can link it on our www.docswholift.com too.
Okay. I'll have all of that on the show notes for this episode. Karl, thanks so much, man. Pleasure connecting with you. Wish we had a little bit more time to dive into this, but
we'll set it up again. We'll do another one.
Absolutely. Thanks, my friend.
All right, man. Bye.
That wraps up another episode of the Legendary Life Podcast. I hope you learned a lot from this episode. What I pride myself on doing with this podcast is not getting the people with the most followers, the people who are the most popular, but the people who have the best information. Why? Because the best information leads to the best results. And that's what I'm about, and that's what I want to bring to you. And there's so many people preaching so many things that are so wrong. And some people really believe in it and they're sincere, but they're sincerely wrong. And then some people, they're just doing it to make money. So I want you to not fall into those traps. And that's why I get guys like Dr. Karl Nadolsky. Can't wait to get his brother on the show too. His brother is just crushing it on social media right now. So it would be fun to get Spencer on the show. Anyway, hope you enjoyed it. Remember, enjoy Christmas. Be the leader by being the person. If you want your family to change, you have to step up and be the person to change first. And that's why I'm super excited to share with you that I'm releasing a new series on December 30th. It's going to be 3 episodes long, and it's going to be everything you need to make 2020 your year. So I'm super excited. And again, going to release it on Monday, December 30th. So stay tuned. Merry Christmas, everybody. And I can't wait to release that episode for you. Talk soon.